This morning we're going to be talking about the laboratory screening for colorectal cancer. I am John Tomaszewski. I am Chief of Service for Pathology and Laboratory Medicine at Health Laboratories. I'm also Chair of Pathology and Anatomical Sciences at the University at Buffalo. I am a practicing pathologist. I've been doing this for 40 plus years, and I'm very pleased to be speaking with you this morning on this topic. I want to share with you a paper by Dr. John Carruthers, who talks a lot about colorectal cancer screening. And there was this very nice paper in a very prestigious journal called JAMA in March of this year. And it was about stool-based screening tests for colorectal cancer, the subject of this session. And he started this off with a little vignette, a made-up case, but it brings a point home. The made-up case is one of a 56-year-old man, no significant past medical history, average patient, seen by primary care physician. He hadn't followed up with the physician's recommendations at his prior visits to undergo colonoscopy. And during this visit, it was brought up again, and he declined it again without first undergoing a less invasive test for colorectal cancer screening. The patient had no history of bleeding per rectum, that's hematochezia, or abnormal bowel movements, but he did say that his father had died from colorectal cancer at age 80. They did some brief lab tests. His hemoglobin was really good, and that's good. So the question around this toy case is, what would you do next, you as the patient's primary care physician? And there are three stool tests that are put in this list. Would you order a fecal immunochemistry test, a FIT test? Would you order a fecal immunochemistry test with multi-target stool DNA tests, an sDNA FIT test? Or would you order a high-sensitivity guaiac fecal occult blood test, oh my goodness, GFOBT, in sort of a quick speak? What would you do? What would you offer this patient? So we need to talk about each of these tests for a couple minutes here. So let's start with the guaiac fecal occult blood test. So this is offered in sort of regular form and high sensitivity form. The high sensitivity form uses a chemical that detects something called peroxidase in a stool sample. Peroxidase is a component something can react with heme products or hemoglobin. And tumors in general will bleed, and that's one of the ways that you can detect them. So what do you have to do for this test? Well, you have to have a portion of stool samples collected. You have to collect them, 3 consecutive stool samples, and smear them onto a slider test card, and then mail that kit to the laboratory for testing. There are some caveats with this testing for preparation. You need to avoid anticoagulants. So if you're on an anticoagulant for some cardiovascular issues, that's a problem. You need to avoid things like Motrin, nonsteroidal anti-inflammatory drugs. You need to avoid red meat. You need to avoid vitamin C. You need to avoid iron. These are all things that can interfere with the test. So it has a lot of interferences to it. The second stool test that we want to talk about is the FIT test, or fecal immunochemistry test. This uses antibodies in the test kit to measure the presence or the concentration of human hemoglobin. So I said just a minute ago that these tumors, even when they're little, may bleed, and so you can use that bleeding as a target for detection in the laboratory. This test now, this FIT testing, has a threshold of 20 micrograms of hemoglobin per gram of feces to call it a positive. So you get the FIT test as a card, and it requires a small sample of stool, and you put it there in the container, and you mail that within 24 hours to the laboratory to get the testing done. The third testing is this MT means multi-target, S means stool, DNA is nucleic acid, and FIT test put together. It's a FIT test along with detection of DNA biomarkers. And I mentioned some of these molecules up here, KRAS and this BMP3. It doesn't really matter for our purposes what these targets are, but there's a series of these targets, and investigators keep looking at better and better targets, because tumor cells will shed mutant or aberrant DNA into the stool from the lining of the colon and the rectum, and this test then can pick up, in this case, both the molecular signature as well as the hemoglobin that you're looking for in the FIT tests. Now, this test requires a prescription. The kit's mailed to you as a patient. You need to collect a full stool sample into a bucket, and this has a buffer in it, and then there's a small stool sample that goes into the FIT testing. So it's a bit more cumbersome collection process. Okay, how do these tests actually compare when you look at them one against the other? So the high sensitivity guaiac test has a sensitivity, and that means of the patients with disease, how many does it find? So it has a range of 0.5 to 0.75, so 50% to 75%. And it has a specificity. That means if you have the disease, or if you have a positive test, how often does that represent disease? And it's got a high specificity of 96 to 98%. The FIT test has a little bit less, it has a mid-range sensitivity, about 75%, and so it'll pick up about 75% of significant lesions that you want to see. And it's got a good specificity of 0.94, 94%. The sDNA FIT testing has a sensitivity of 0.93 and a specificity of 0.84. It's a little bit less specific. So what that means is you get a positive test and you get a colonoscopy, and it's a little bit more likely that they're not going to find anything on the colonoscopy. So there's a different cadence in doing these tests. The guaiac tests, or the GFOBT tests, are yearly. The FIT tests are yearly, and the sDNA FIT tests are every 1 to 3 years. The tests that have been out there the longest are these guaiac tests. You may know them as a hemocult test. You might know that word. The FIT tests have a good long history of about 20-some years. And we'll talk about the tests we're going to be using in Colorectal here in a minute. And then the DNA test, you might know this as Cologuard, for example, is the newest on the block and has the kind of the least history of study over time. We should also just mention the costs for these screening tests. If you look at the 2022 Medicare fee schedule for reimbursement, the guaiac tests, the high sensitivity guaiac tests, are about $5. The FIT tests about $18, and the sDNA tests, FIT tests, are $509. So there's a sizable differential there in the cost of these tests. This is a little bit of a busy slide, but once again from Dr. Crothers, a different publication. But let me walk through this in terms of the advantages and disadvantages. We already talked about the sensitivity and specificity. But if we look at the guaiac test, the fecal occult blood test, FOBT, The advantages are that there has been a long time of usage of this test, and it's pretty clear from randomized controlled studies, and these are the best kind of clinical studies that you can do, that there is a reduction in mortality. So it's very clear that these tests do save lives. What are the disadvantages? Well, you have to do it annually. It's an indirect test. We talked about all the things that you have to be off of or avoid, and it's because of this peroxidase. So you're really testing for peroxidase, and you don't want these interferences. So there's false positives. These dietary modifications are just what we said. You have to do 3 times. You have to test 3 days in a row. And it also is not real sensitive for what we call advanced adenomas. Those are the small tumors, but the small tumors with bad cells. And so it's not real sensitive for that. And that's actually true of all 3 of these tests. It mostly detects neoplasms that are in the lower part of the colon, the distal colon. The FIT tests, the advantages are it can be both qualitative and quantitative. So the fecal occult blood test is just qualitative. So you can actually measure amount of hemoglobin that you have. It detects hemoglobin, so it detects what the tumor does, which is break down and bleed. And you only have to do a single sample, so that's good. While there's not as much experience with the FIT test as there is with the guaiac test, from the studies that are available, the inference is that there is a mortality reduction from these fecal occult blood test studies. So disadvantages, once again, it has to be done annually. If you hold on to the specimen for a long time and you don't mail it in, the reliability goes down. You really do need to administer this test. This is a lab thing, as a quantitative test to make it work well. And it has the same problems that we saw with the guaiac test, poor sensitivity for advanced adenomas, and detects mostly distal neoplasms. The DNA test, the advantages are that it detects human DNA, so it kind of gets at the molecular biology of the test directly. When it's combined with the FIT testing, there is an inferred mortality reduction over the guaiac tests. It can detect neoplasia both on the right side, or the distal colon, or the colon most proximal to the body, and on the left side. So it detects neoplasms throughout, and there are no dietary restrictions, so that's good. The disadvantages are that it's a high-cost test. The interval that's out there for 3 years really doesn't have a lot of data around it. It needs more analysis. And a portion of the test is actually based on the FIT part, so it's a little unclear how, when you get a positive, which one you're getting a positive for and how much is contributing to the positive call. And it's still, it's got better sensitivity for these advanced adenomas, but not great still. So let's go back to our JAMA patient for a minute. So what would you do with this patient? Well, remember, he had a family history of colorectal carcinoma. Dad died at age 80. You wouldn't really want to be screening him with stool testing, because he really needs the definitive test. He needs to be screened by colonoscopy. So colonoscopy would be recommended for him, but he's pushing back, and he doesn't want to get the colonoscopy. So he gets one of these stool tests, and it's positive, and the positive test must be followed up with colonoscopy. The only way you make a diagnosis of cancer is to go in there and get a piece of tissue, get a biopsy, and have the pathologist look at it and diagnose what it is, whether it's an adenoma, whether it's a benign little neoplasm or tumor called a hyperplastic polyp, whatever it is. That's the only way you get a diagnosis. So you need tissue to get a diagnosis. You need colonoscopy to get that tissue. You have to have a colonoscopy. So this patient should have had a colonoscopy. But whatever you do, do something. So I like this quote from Dr. Carruthers: the best test for screening average risk individuals is the test that gets done. Do something and you'll be better off. So, summary points on stool-based testing. There are three basically stool-based tests. The recommending bodies recommend that colorectal cancer screening for an average risk person begin at age 45. So the three tests are, as we said, high sensitivity guaiac test, fecal immunochemical testing, FIT testing, and then the DNA stool FIT testing. And a positive stool-based test must be followed up with colonoscopy. Those are the fundamentals that you need to take away of information from this session. So what's Kaleida doing about this? So Kaleida recognizes that out there in the Kaleida clinics, GPPC, and partners, there's a variety of tests used. There's FIT tests, there's stool hemoccult cards, there's Cologuard, and to date, Kaleida Laboratories did not have a uniform, easily accessible screening method to help patients really engage in screening program. So we've developed a partnership with this company called Polymedco. This is their instrument off on the left-hand side of this image here. And Polymedco specializes in FIT testing. And this testing is automated. We have this installed and validated at our main laboratory here at the Flint Road Center for Laboratory Medicine. And the assay is up and running now. So we're going to focus in on FIT testing. So moving forward, we are rolling out with GPPC and Glynn partnership practices this kind of testing for our patients as sort of the standard recommended tier 1 testing. And this would be colonoscopy every 10 years or OC FIT, this is the name of the test, annually to average risk patients. And if they decline either of these options, then Cologuard could be offered. We've made this decision based upon these recommendations by USPSTF and cited some of the data that we've gone through here. And sort of this is being recognized as what they call a first tier testing with colonoscopy and annual immunochemical fecal testing. So that's where we're going with our primary recommendations. What's it look like for you? Well, this is what a test looks like. It's a little package with a card in it or container in it. You have to sample one bowel movement, and there's a little sample probe. It's only a few micrograms of stool that has to be collected. It goes into onto this biodegradable collection paper. There's no dietary restrictions. This is a test for hemoglobin. We will provide this mailer, this pre-addressed postage prepaid mailer. One of the good news is that this particular product is stable for 15 days. And so if you forget to mail it the next day, still good to go. Get it in the mail. It goes to a post office box. We pick that up by the laboratory, and then we do the testing, and we've integrated this into the results into the lab information system, which interfaces with the electronic medical records from your physicians' offices. So this is a package meant to be easy so that it's not a burden for you getting it done, so that you engage in testing. So I want to thank you for listening to this talk. Hopefully this is something informative to you, useful for your health and wellness and your personal engagement in your health and wellness. And so from the entire team at Kaleida Health Laboratories, thank you for attending this HealthyU.